So would the other speakers join me? And we have about 10 to 15 minutes of questions and answers. In particular, Don didn't have an opportunity for questions, so my apologies to him, but we can take them now. Sure, please.
My question to Don is, Don, are you listening? So it's interesting. So, you know, I like dendrimers, but then, you know, the permeation question that you brought up around small size, and so really, what is the threshold? Maybe Hazy may have some comment, because liposomes are, you know, we talked about it yesterday about the size, and then so the 100 nanometer liposomes are just fine in terms of permeation.
Okay. So Neil, that's a very good question, because if you look at liposomes, liposomes are not robust. They're not covalently bound. So they can fragment. They can reduce under pressure or going through small orifices. They can become totally disorganized. You know, they're not exactly the dimension that you may determine by instrumentation before you inject them. When they're in vivo, they can be squeezed down to many different sizes. A dendrimer, being covalent, cannot be. And so when you're making covalent organic structures, you have to really pay attention to that rigid size that you can't get below. It's a Pauli exclusion principle. You know? You can't violate squeezing the atoms in. Yes?
I didn't hear all the question, but the part I heard was enough that it needed an answer. Well, liposomes are non-covalent structure. You can make them covalent, but I don't think anyone wants to do it. It really didn't prove that it's better in any way. And we can make them in many, many sizes, starting from the minimal size, 20 nanometer, going up to the sky's the limit, I think. Depend on the application. I think the point about penetration is really critical, what you said. But the way to understand it is a little bit different. The problem is that we can divide the drug, the nanodrug we use in two groups. Some drugs have some targeting device, and they will target to certain cells, and either internalize or not. What Dan Pear said, we studied it many years ago. We have long-time publication about it, and many other people have. So that's one thing. The other are liposomes that go to the cancer, and they don't bind to anything. They're kind of free-floating there, if we can say it, because tumor is very chaotic and very difficult to free-float there, but basically they are. And what happened there, the smaller they are, the deeper they can penetrate.
Yes.
Okay,
yes.
But that's not the real story. The real story is, will they release the drug or not? And
right.
To what level they release? They can go anywhere, and we did liposome with cisplatin. They were wonderful. They were non-toxic. They went to the tumor, but they didn't release the drug. So actually, I didn't develop them, but I was asked to solve the problem why they didn't work. And this was a project of the same company I did a doxil with, and I found that they simply don't release the drug. So if they don't release the drug, you don't get activity, as simple as that. So I think the point is, will the drug find the way to the tumor cells? That's the main question. If it does, or to any other inflammatory cells, whatever, they will do the job. If not, they will not do the job. How we can control this? What is the best rate? Should it be fast, slow, medium. We don't know. There is no answer. No one did really a kind of elaborate experiment, try to prove what is the rate of drug release which is optimal. If you do it too fast, we compare too fast to too slow, and we found too slow better. And the reason is, except for the liver tumor. In the liver, I don't talk about. That's a very different system. But what happened, some of the drug really is not used. It just go out of the tumor very fast if it's released. So, but still, we don't know what is the optimal rate. And that's very critical to optimize the treatment. And I really try very hard to do it, and I don't know yet.
So do we have an answer to an ideal size? Because I listened earlier on to Professor Kataoka's talk where very clearly he showed the importance of 30 nanometers over 70 nanometers.
That's
I
right.
heard Don say again that,
Yes,
that
in fact,
with Bob Langer,
he said,
they're
Professor Kataoka several years ago at this conference said, size really matters. I remember that. Is he in the audience?
There's a lot of literature on the liposomal side, for
Yeah.
instance, doxal and effectiveness of things in the 100
I
nanometers.
think small size has advantage and has not very little disadvantages.
Yep.
They go to places you don't want them to go.
That's right.
And that's a major problem. I mean, we have to face it that when we do with this technology, there is the dark side of it. And the dark side can kill the product. And many times it kills the product. We have to be very careful. It goes to places you don't want to go. If you inject very small particles, there are quite few publications show a lot of them go to the brain under condition you don't want them to go to the brain. So you have to be very careful.
But let me then ask you, would you make a 30 nanometer liposome? I don't think so.
I can make 30 nanometers.
You can, but would that be a size that most people would not make a liposome of that size? And yet we've heard these two examples of materials where clearly the 30 nanometer was. I can say that for pancreas cancer, and I'm talking about animal models here, but rigorous models, where we have a transcytosis pathway that we can follow, and those transcytosis vesicles actually can take particles through easily of a size range of above 100 nanometers.
Yeah, absolutely. Yeah.
So how do we reconcile this? Are these different observations based on individual studies, or is there an ideal size that we can say, this is what we should aim for?
Well, there, it's becoming old work now that I did with Paul Lauterbur back in the early days, where we were looking at real-time MRI. We were able to use denomers with gadolinium surfaces to look at real-time excretion patterns, and we found there was almost a cutoff point for excretion through the kidney, and it was right around 8 to 10 nanometers. If you were below that, so if you're seeking for eliminating your drug eventually, or your conjugate eventually by a urine excretion, you want to stay under 10 nanometers. However, if you operate between roughly 8 to 15 or 20 nanometers, you are in the right size to get deep into a cancer tumor. And it's questionable whether you're going to have urinary excretion or through the bile. But the lower you are below, the lower you can remain below 10 nanometers, the better your urinary excretion is going to be. I believe that's been observed for quantum dots too, for the quantum dot guy at MIT. He said he saw the same thing with his quantum dots, stay below 8 to 9 nanometers. And if you look at proteins, they follow those same patterns. The large proteins don't ever get excreted through the urinary tract. If you have a bladder or a kidney membrane problem, you start observing albumin, which is at that 8 nanometer size. And that's the magic. That tells you, it's almost an indicator that you got a problem with your renal membrane because the albumin starts showing up. And it seems to all come together and make sense.
But now, let us say we want to make a compendium diagnostic now to determine if a tumor has enough of an EPR effect
Yeah.
to sort out treatment. What size are we going to make that
Yeah.
MRI imaging
I
particle?
think it's a great question what you ask now. Great, very important, and this can change the whole field. Actually, we do some project with a guy in London on both on cancer and on inflammation. And what we do, he's the one inventor. I'm not. I just kind of hitchhiking on him basically, and it's very nice to do it because it's really great thing. What he succeeded to do, and we help him a little bit, is to take liposome already loaded with the drug we want to use. Let's say we take liposome with doxorubicin, we take liposome with steroid we're using, we take liposome with antibiotic we're using, and we found a way to bind zirconium to this drug. Inside the liposome. We have some shuttler that take the zirconium from the outside and have a very effective loading, almost no free zirconium, and then we inject it to the animals. Now we are planning for a clinical trial with this, and you can do it with any drug. And basically you follow your own drug, your own liposomal drug. If you can have the same method than you can with any other drug, because they are very nice way to bind zirconium. Zirconium has the optimal, it has a half-life of 3 days or 72 hours. It's really perfect, you know, to what you want. You can follow pharmacokinetics and biodistribution for a matter of 15 days or so. That's what you need. And you can see PR effect, and you can see, I mean, one of the fantastic things you know, if we have time, I'll show you the slide we did on inflammatory a model that they have of that they inject something and all the joint get inflamed, all the joint all over the body. And then we inject our liposome with the steroid labeled with zirconium. And actually, we look at the image and we saw many, many spots. And when they looked just physically, they said there is no inflammation there. So I told them, do histology and let's see every place there was label, there was liposomal with zirconium. And the other places, there were not exist. So you cannot ask for a better targeting, passive targeting, but than this. So I think it can be done. And that's one of the directions we all shift is find a way to label our own system, not another like, but the same. And then you can claim that it's working. Your system will work. You get EPR, you don't get EPR, whatever the case is. Is it worth to treat the patients? And that's the idea. And you know what? When I came to the drug companies, they said, leave us alone. We don't want it. We want to give to any patient.
Interesting. Okay, are there any, we essentially, Tuan?
To that, so I think Gezi is really full on now. So, but the key thing is that you would want to implement this strategy if you're developing a new drug product, right? Because it's obvious that with a drug that is already approved for multiple indications, you want to keep them in all those patients. But if you want to make sure that you go from phase 2 to phase 3, it's really important that you leave out a certain group of patients that are unlikely to respond. And there, it doesn't really matter if it's 10 nanometers or 100, but that you have something at hand to say this population is unlikely to respond. And then this is probably the most elegant strategy. It's a question whether there are new drug products coming up that allow for the same type of labeling. But this is the best case scenario. So I hope to see much more of that.
Thanks, man. One more.
You have to think about it from time zero. That's what I'm saying.
I would like to ask one question to Professor Thomas Ledon. It was a great talk and inspirational as always. So thank you very much, first of all. I would like to say, I would like to ask you to clarify one option about the dendrimers. So finally, lessons learning from Jim Baker failure. I would like to make clear it was because of the linker, that the linker was not cleavable, could not dissociate the drug from the dendrimer, or because it was that the dendrimers cannot be upscalable. I would like to be clear in this answer, please.
it was my understanding, and I had a discussion with Scott McNeil in the audience. I had a discussion with him at a meeting we were at together here in the last month, and he said, it's 10 years, I can talk about it now, about the Baker issue. And he said it was a non-cleavable linker problem, which I suspected for some time, but I had no proof until actually a month ago when Scott McNeil shared that information with me. And he, in fact, said it was a very beautiful, robust, non-toxic, targeted dendrimer that would go to the targeted disease site, but it wouldn't release the active pharma to kill the tumor.
That's what I said, exactly what I said.
Yes.
You don't release the drug.
That's correct. But
Better give,
Professor,
give water to the patient.
That's right, and that's where it hit the wall. That's where that's a lesson to be learned. And then my other colleague, Frichet, he made a Schiff-base cleavable linker, and he showed in one paper that never gets mentioned how he completely suppressed tumor size by having a cleavable linker on a dendrimer with the right size. So I had those two pieces of information, but I never really knew for sure about the Baker case until Scott McNeil shared that information with me about a month ago.
Well, I want to say, so for purposes of cousin, there's been interesting, so I'm sure that at dinner time there will be lots of interesting discussions. I want to take the moment to thank the panel for excellent talks, excellent discussion, and also excellent questions from the audience. Thank you very much.
Thank you.